And welcome everyone to another Smart Money Circle update. I'm Adam Sarhan. With me today is Mitch Steiner, who's the CEO of Veru Pharmaceuticals, ticker symbol VERU. Mitch, thank you so much for taking the time and welcome to the Smart Money Circle.
Thank you for having me. I appreciate it.
So, Mitch, I always like to ask, can you please tell us a little about your journey and how you got to where you are today?
Yeah, great question. I actually started out as I'm a physician and trained in urology at University of Tennessee, excuse me, at Johns Hopkins, and then w was a chairman of urology at the University of Tennessee. And so that journey took me about, I don't know, 17 years or something like that. And so I came late, if you will, to biotech. But in 1997, formed a company called GTX that we took public with Goldman Sachs. And in 2014, I retired from that company and started a new company called Veru, Veru. That became a public company in 2016, late 2016. And so I've been now in drug development for about 24 years and having a lot of fun doing so. But if I had to define what drug development's all about and what's different than what I did before is I took what people taught you in the books and
Yes.
applied. And what I'm doing now is I'm at the cusp of the unknown and the known. And the challenge is how do you bridge that gap and make something known so people can use it. And so that is the real challenge of drug development. And it's been quite thrilling with high highs and low lows.
I love that, bridging the gap between the known and the unknown. And then, of course, you've got to educate the public about it too, which is a whole nother
Well,
process,
you try to educate based on what you know,
right?
and and then you have to give them comfort about what you think is going to happen in the unknown, and then you have to add on top of that just the science. Then you have to add on top of that regulatory unknowns and patent unknowns and all these other unknowns that can influence it almost as much as the science.
I love it. So let's talk about the company. Can you please tell us what Vero does and some of your competitive advantages?
Yeah, so Veru has just recently pivoted pretty hard. We started out as an oncology company with a base product that generates revenue. And the base product has been good to us, so we've been able to use that money to do drug development. We had an oncology portfolio, and we woke up one day and realized that we were in the middle of the pandemic. So this puts us around 2019. So we took one of our oncology products. And like everybody at that time, they were using chewable Clorox and all the other stuff, trying to figure out how to go after COVID. But we actually had a drug in oncology that got repurposed, and we did a phase 2 and a phase 3 in 3 years, and actually ended up in an AdCom. But we ended up at a point where the drug worked but the COVID went away according to the FDA, and that was my point about sometimes you have the science works, but the regulatory environment doesn't. And with that said, we took a step back, and so Veru now has focused another repurposed drug that we were developing called enobosarm. And enobosarm has some really interesting features. It was a drug that started out at GTX, my former company. And we were very fortunate in 2019 to license it into Veru. And the beauty of the drug is it was a time when we were trying to make hormone drugs safer. So like testosterone has, as you know, its problems. But if we're able to create something that does some of the similar things you want that testosterone does, and some of the things it doesn't do, you don't do, and you make it non-steroidal, meaning it's an oral agent, and you can make it a drug, make it druggable, that would be interesting. So about 8 months, 9 months ago, we caught wind of this incredible movement in biotech around obesity. And the problem with obesity is everybody knows it's a problem, but the drugs that we had in the past can only cause weight loss of less than 5%, maybe max, and there was a lot of side effects. And then in came these GLP-1s, like Wegovy and Zepbound and those kinds of drugs, and they pharmacologically created tremendous weight loss. And the problem with that weight loss is about 40% of the total weight that you lose, and this is true for Wegovy, in about a year turned out to be muscle. So when you create a starvation state with these weight loss drugs, it's non-selective, meaning that your body doesn't know you're not reducing fat or muscle with direct effects. You're doing it by causing a suppression of appetite. So the body doesn't know. You start acting like you're starved, and you lose muscle and you lose fat. And so we heard about 40% of that weight loss was muscle. We said, wait a second, let's dust off enobosarm. It's a drug that builds muscle, builds bone, reduces fat, but you don't have the unwanted side effects like masculinization in women and potential effects on prostate in men. And can we, move the development into an area where it's becoming quite apparent that, all these weight loss drugs are doing a great job taking weight off, but they all have the same problem. It's non-selective. And in older patients, that's a problem because older patients have loss of muscle just from aging. And so if you're older and you have less muscle and you're obese and you take one of these drugs, you don't have a lot of capacity and they can get into trouble. So that's how we got into it about 9 months ago. And in that 9 month period of time, we rapidly got FDA to give us a green light to start a study with enobosarm in combination with Wegovy in older patients. And we've already, as of August, end of August, fully enrolled a study of 168 patients. And here we are sitting with the opportunity to have data in January 2025. So talk about a hard pivot. That was a hard pivot. And again, this is a drug that can be used with any of the agents that cause weight loss because they all have the same problem with muscle loss. So I would say now Veru has singularly focused on metabolism and obesity and an oncology pipeline and our has been paused so we can singularly focus on this. And COVID, we're just not doing. We told everybody that even though we have a drug that reduces deaths, the investment community and the world has not learned from unfortunately from the mistakes. And their feeling is now vaccines can handle the problem. So if that's the case, then we should be focusing on what we think will provide tremendous shareholder value in what has become, soon to be $1 trillion markets, not $1 billion markets. When you start talking about obesity and the benefits that obesity can anti-obesity drugs can provide mankind.
I like that a lot. So what you're doing is Ozempic and Wegovy, all these guys, they reduce weight, but they take away from muscle, and there's bad side effects of that losing weight. What you're trying to do is like what you did with COVID, I guess, is lose weight, but in a better way. Is that a good way of
Right.
explaining it?
So with COVID, it was a different drug. It was called sabizabulin. So it actually was an antiviral and a drug that was an anti-inflammatory agent. But enobosarm has always been a muscle drug. And again, because it's got a testosterone base, it makes sense, a performance drug. And so what we did is we repurposed that oncology product in cancer wasting, because how do people waste in cancer? Cancer causes them to suppress their appetite. Well, that's how you know you have cancer, unfortunately. You say, I lost this weight, I lost my appetite, I can't eat. So the cancer is acting like Wegovy, it's acting like Ozempic because it's causing you to lose your appetite and your body wastes. So when you look at a cancer patient, you say, at the end of their journey, you say, this is terrible, they've wasted. But, many of these patients may have started obese and they've wasted. And the question is, and what we see in those patients, they lose a lot of muscle. So the way to think of it is we took all that information, what we've seen, it's been 5 clinical trials, about 1,000 patients of data over the last 10, 15 years. And so we built on that. So it wasn't like an overnight success. It was literally saying, okay, we know in men and women, we can build lean body mass, we can improve physical function, we can decrease fat, decreases fat. And so now let's take that and move it into this area where it become very, very apparent that this muscle loss can't continue. The exchange rate, I like to call it an exchange rate. There's an exchange rate to lose fat. The exchange rate, if you lose 40% of your total weight of the year is muscle, or in some cases 50%, then the exchange rate is a pound for pound. So in other words, if you lose 2 pounds and half of it's fat and the other half is muscle, then that's a pound for a pound. And so in patients that have very little muscle mass because they're older, and this is this is in the United States, interestingly, the patients that have low muscle mass and obesity is about 30 million people.
Oh
30 million.
wow.
In older patients, it's much higher. In older patients, 42% of older patients, over the age of 60, could benefit from a weight loss drug. About a third of those patients have critically low muscle. It's called sarcopenia, critically low muscle. So that means if they have that exchange rate with a pound for a pound, you can get rid of a lot of fat. You've seen people that get really chiseled, they get rid of that fat. You can't get chiseled by losing muscle. You die.
Right. Right.
Start
Right.
die. So you've got to hold on to that muscle. The idea is not to build bodybuilders. The idea is, can we just hold on to muscle? And so because of our experience and not just Veru, but Veru's leadership, many folks came from GTX that was working on frailty and working on cancer wasting, and now we're at Veru. We said, okay, now let's turn. And this is very true with a lot of some of these other companies that have muscle preserving drugs. They're going after mechanisms that have been tried in other conditions, like muscular dystrophy and frailty and cancer wasting and that kind of stuff. And now applying it into this area when we know, if you can just preserve muscle, that would be great. Now, to be clear, muscle is not just as we think about it important for function. It is important for function, especially older patients will get potential to get weak as they lose muscle, and when they get weak, they can fall and break their hip and lose their gait. In fact, the Wegovy label had been recently updated to show that there's about a fourfold increase in hip fractures and pelvic fractures. So we're starting to see clinical relevance of this muscle loss. But muscle's a metabolic tissue, meaning that it's not just a functional tissue. It also plays a role in your weight loss journey. What do I mean by that? Well, I made the point that as you lose weight, these effective drugs shut off your appetite and slow your gut down, and you start losing weight, and your brain's getting this signal from the drug that says stop eating, and then all of a sudden you hit what's called a plateau. They call it the Ozempic plateau, meaning that you stop losing weight, and people get frustrated because they hit a brick wall. And why they stop losing weight? One theory is because if you have an exchange rate of a pound of muscle for a pound of fat, you're losing muscle. And the body's not going to let that happen. The way the body handles the loss of muscle, it tells the brain to eat. So you got a drug that tells you not to eat,
Right.
called the weight loss drug. And then you got your muscle saying, guys, this is not going to work for me. You have to start to eat. So you hit a brick wall called plateau. So if you're able to shut that signal off by making muscle, preserving muscle, and the only signal the brain gets is not to eat, then maybe you can lose even more weight because you're not getting that signal from muscle. And another phenomenon that's happening with the weight loss drugs that's very interesting is that patients are getting frustrated because they're finding out they're having what's called a rebound weight gain. What that means is they lose this weight and say, you know what, I'm happy at this weight, or I'm not losing any more weight, I want to stop. Or I'm an older patient and I got into trouble because I can't get out of a chair, I can't go up steps, I feel weak, fatigue. Or there's some GI toxicity related to the weight loss drug, nausea, vomiting, I need a break. But as soon as they stop the drug, they get this rebound weight gain. So what's happening is their muscles depleted. And we've seen this in the starvation state. When that happens, the body tells your brain, eat, and you overeat to compensate for that muscle loss. And you get what's called collateral fattening, meaning you replace with fat first before muscle. So you've kind of made the patient potentially worse because you're taking the muscle away with the exchange rate. And now you stop the drug and you put the weight back on. It's fat, not muscle. And that's the frustration. And so if you leave muscle alone, you don't deplete it, then one potential possibility is you can blunt the effect of the the regain of fat, that rebound regain of fat. So in comes enobosarm, and the idea for enobosarm in our phase 2b study that's running now, 168 patients who were randomized, is we want to address those three questions. First question is, in older patients, can we stop the physical decline? Second, in patients that have a plateau, can we break through that plateau? Can we show that by holding on to muscle, we can lose more fat? It's a body composition endpoint. And third, if you stop the GLP-1, if you stop the weight loss drug, can you blunt the rebound so you can maintain that weight and not feel like you're going to get it all back and you get frustrated. So that's the phase 2B that we're doing. It's a proof of concept. The FDA green lighted it in February, put our first patient on the end of April, and we fully enrolled it. And the importance of that design is that we're measuring not only, and the endpoint, by the way, is muscle, lean body mass. So again, you're taking a muscle drug, you're putting in patients with a weight loss drug, and our endpoint is muscle. Now, people say, well, is that a regulatory endpoint? That's not the point. The point is you want to pick a dose. And so you want to pick a dose that best holds on to muscle, and that's your endpoint. And we're gonna be measuring fat loss, we're gonna be measuring weight, we're gonna be measuring function. So I think we're very, very different because we're entering this game, this important it's not a game, it's really, I mean, when you see the tremendous benefit of weight loss, it's not a game, it's a game changer. I mean, it really is. I've never seen in my lifetime a drug that has so much potential to do so much good, except it's like everything else. You start out with a great drug, then you find out where the problems are, then you find out how you can fix those problems so you can optimize and make that weight loss journey much more effective. That's why we call our trial the quality trial, because it's not just the how much weight loss you lose, how much weight, how fast you can lose it. What's better is can you lose that same amount of weight and concentrate it as fat loss, because that's where the problem is, and leave muscle alone. So you have a better quality of weight loss as opposed to a quantity of weight loss.
That makes perfect sense. So the downside is losing muscle and weight, and when the normal Wegovy and Ozempic, all those kind of guys, what you're trying to do is, if I understand this properly, is keep the muscle, 'cause that's the important stuff, that's the good stuff, but just lose the weight and then keep the weight off. Is that
Right,
correct?
right.
Yeah,
And by keeping the muscle, the idea is that the body should be able to get more fat loss.
right.
Okay, because if you have muscle, then you don't have a signal because of lack of muscle telling you to eat, and so you have a push me pull you where the drug says don't eat and the muscle says eat. That goes
Yeah,
away. Second thing that
gotcha.
happens with muscle is that you're more active. You have muscle, you burn, energy goes up, and when you have energy, you burn fat. And third, the enobosarm by itself has a direct effect on fat, independent of muscle. And so if you have those three things going over time, then you're going to accomplish what you want to accomplish, which is to lose as much fat as you can lose and leave the good tissue, the good metabolic important tissue alone. And again, and the very, very important point about our approach, some people say, well, look, the field is so competitive. It's not competitive. We're not trying to be a weight loss drug. We're not trying to go up against Wegovy and Zepbound and all these drugs, all these newer drugs. Let them fight. Let them all fight it out because they all have the same mechanism. They stop appetite. They suppress appetite. So if you suppress appetite, you're going to have a component of muscle loss. And so we could potentially be used with any of those drugs.
Got it. No, makes perfect sense. Well, next question for you, Mitch, is how do you handle risk, and what are some mistakes you see people make with respect to risk management?
Yeah, so risk is a problem in any field of drug development, and what you have to do is you got to be extremely patient. And the reason you're patient is because that you have to play the drug out. You have to run the clinical studies. Now we're a little bit fortunate because we have 27 clinical trials that we've done with enobosarm, and five of them were with muscle. So about 1,000 patients, and our safety database is about 1,600 patients. And so in many ways, we've kind of de-risked some of the safety. But as you know, every time you go into a new patient population, you have to address the safety concerns that could potentially come up with that patient population. So, but it's always good and best to go into something with some knowledge. It's not a first in man kind of experiment. It's we've got a lot of experience with it. So from that standpoint, we've reduced quite a bit of risk. Um, the other thing that typically happens with clinical trials is enrollment. You always find that you have the best intentions to enroll the trial, and you have these inclusion exclusion criteria, and it just doesn't enroll as quickly as you want. This is not the case here. This is such a hot area. There's so much demand for weight loss drugs that I've never seen. Essentially, we've enrolled this study in 3 months, 168 patients in 3 months. I mean, this kind of stuff is unheard of. Now, what it does tell me is that when we're ready to do our phase 3 program, I mean, you can enroll a lot of patients pretty quickly. And so that risk has been mitigated just by having the experience and having those clinical sites in place. Um, to me, the biggest risk is going to be biggest risk, just in general, not just our drug specifically. It's always regulatory because you have to make sure that you check all the boxes. What you think about scientifically and from a regulatory standpoint, sometimes don't match up. I'll give you an example. So the regulatory position is how do you develop a drug like this? Okay, what do I mean by that? Well, we all agree scientifically, if we can put muscle on the patient, hold on to muscle, then that's a good thing. Okay. But from a regulatory standpoint, you have to show that it benefits the patient, how a patient functions, feels, and survives. Okay. Or feels, functions, survives, same three. So in other words, just because I put muscle on and held on to muscle, it's cosmetically nice but did you do something that's clinically meaningful for the patient? Okay. And so from a regulatory standpoint, the potential endpoints there is to show more weight loss. So in other words, maybe by having muscle, as I mentioned, that potentially can cause even more weight loss in the long run because muscle burns fat. You don't get that plateau. You don't get the rebound. So there's many ways to show that you can have a better quality of weight loss. Got that. The other part is that we can also show that the lean body mass that we've kept on to the patient stop the physical decline. Physical decline is scary for older patients and younger patients too. You don't want to lose all this weight and find that you're having physical issues. And so if you can show a benefit in physical function, then that is something clinically meaningful too. So we have an opportunity with our drug, unlike a weight loss drug, just shows just weight loss, and you just have to hit 5%. And the question becomes, okay, I mean, if I'm weight loss drug number X, and I lose 10%, and there's weight loss drug number Y, and they lose 15%. Is 10% and 15% different? Is that 5% different? You see what I'm saying? But now if I did 15% and I showed a functional benefit, you win. So there's you got to be clever about your endpoints. Insulin resistance is another way to go at it. HbA1c. In other words, what are you doing with that additional weight loss and holding on to muscle that's going to benefit the patient's weight loss journey? And we have a lot of opportunities to get that kind of information and create the clinical meaningfulness package.
Gotcha. It makes perfect sense. How about timeless lessons and mistakes that you'd like to share with the audience that you've made, you've seen other people make, and how do you
Yeah.
avoid them?
Yeah. Well, the best thing is there's a lot of mistakes and that happens in drug development. When you're in the field of the unknown, and you always say, well, if I just knew, if I just knew. So I do think there's a benefit to have a management team involved in the company. And our management team is a perfect example of that. That is well seasoned because it's not that you're not smart. There's a lot of companies that have smart people, but part of being successful and potential for success is the experience. And the experience comes from being both right on things and wrong on things. And sometimes your experience may not go along, I would say a different way. Your thoughts, based on your experience, may hit a tide that's coming against you. Okay, but because of your experience, you know what FDA wants. You know what the science tells you. What are the possibilities that you can, enroll the patient with the right patients in the right place and that kind of stuff. Because you get that kind of experience. Which countries to go to, not which countries not to go to, and what EMA thinks versus what FDA thinks, what Japan thinks. So all that kind of gets pulled into the blender, put into the blender, and you come back out and say, okay, this is the path we're going to take. So our clinical trial that we're doing is a perfect example of it. And that is that when we initially put the trial together, people said, well, lean body mass is not a regulatory endpoint. And now people have warmed up to understand the reason we did that is because in the phase 2 setting, it's a muscle drug. So if you're a muscle drug and you want to know what dose to pick, then pick the dose that gives you muscle. Save the weight loss for the 1 year trial that the FDA is going to make you do 1 year plus, because you'll have plenty of time to show the weight loss and and hit function, hit all these endpoints that you can power in your phase 3 program. Because what people try to do too quickly in drug development is they want to show everything at once. It's either boom or bust. And that may not be smart. I think with the experience is get collect the right information, and drug development is an iterative process. You take it step by step by step. And if you skip steps, then sometimes you may never be able to have that opportunity to take a step back and come back ahead.
No, it makes perfect sense. So I love that.
Yeah.
The experience is very, very powerful. To make sure you understand the regulatory environment, very, very powerful. Know the unknowns, like the risks of know what you don't know and know what you know, and then don't try to pretend like you know what you don't know. So that's really powerful as well.
And furthermore,
Yeah,
if you're on the right path, then hold steady, meaning that even if the tide's against you, if you're convinced that you know how you're navigating through the unknown, because otherwise you're going to flip-flop and you're not going to get the answer.
got it. And then final question for you today, Dr. Mitch, is what's the best piece of advice you'd like to give the audience about life, about business, biotechs, anything you want to go, or your 30-year-old self?
No, I'll tell you what it is, first of all, it's, in order to go from known to unknown is you have to know everything in the known. So, and that's not hard to do. Thanks to Google, PubMed, and good key opinion leaders, ask the hard questions and get to that edge, the edge between known and unknown, and stand there and feel comfortable, right? Then when you hit the unknown, you have to be resilient and persistent. Resilient and persistent. I mean, again, especially in drug development, because you want to learn and make it iterative, and you have to have a lot. Remember my opening comments: patience. You need to have patience, and so I think that's the way to get as much information as you can and go forward and hold on. I really do think that what we represent today at Veru is a 10, 15 years of experience from picking a molecule to seeing the molecule through several conditions with success, in most cases, some cases not, but you learn from that. And now stand at what's the biggest opportunity in weight loss today, and it is, can you hold on to muscle and create a better weight loss journey so that you can end up getting the cardiovascular benefits? I mean, if you have half your patients drop off the weight loss drug because of side effects within a year, that's the data. Half to 60% of patients will stop taking the weight loss drug. Then you're not going to get the cardiovascular benefits. So if you want patients to get the most out of a drug, it's not just the efficacy, it's the safety as well. And so I think our company clearly represents that. And I think the way our approach to the clinical phase 2b clinical trial and how we're going to think about the data as we get it will all be through a lens of experience, persistence, and just good solid regulatory thinking as well.
Love it. Well, Dr. Mitch, that's been absolutely fantastic. What's the best way for investors to learn more about Veru and everything you have going on?
The best place to go to our website and to verupharma.com. We put up our most recent presentations on a regular basis. We put up all our press releases, and also all of our publications. And that's the best place to get information. You can always reach out to our company. Sam Fish handles investor relations and communications, and he can be reached through the website as well.
Beautiful. Well, thank you so much for coming on the show, and hopefully we'll have you on again soon. This was fantastic.
I appreciate it. Bye now.